You're listening to Who Said, a Cardiology Board Review Series. No fluff, just facts.
This episode will talk about complications of MI. We'll go over intracath complications, post-MI aneurysm and pseudoaneurysm, post-MI arrhythmias, post-MI papillary muscle rupture and interventricular septal rupture, post-MI free wall rupture, stent thrombosis, and general post-MI findings. So let's start with intracath complications. If during left heart cath the patient has a decrease in sinus rate to the 40s, concomitant AV block and hypotension, that suggests a reflex mediated mechanism, the Bezold-Jarisch reflex, rather than AV block due to ischemia. The timing of the Bezold-Jarisch reflex is often immediately after the relief of the arterial occlusion by POBA or stent, usually in inferior STEMI. The mechanism is stimulation of cardiac sensory receptors, particularly concentrated in the inferior wall of the left ventricle, with non-myelinated vagal fibers that increase parasympathetic activity and lower sympathetic activity. Prompt administration of atropine is the first step, followed by fluid resuscitation. Atropine is the preferred treatment due to its effect in antagonizing both bradycardia and reflex cholinergic vasodilation. AV block refractory to atropine may be treated with isoproterenol or transcutaneous transvenous pacing. An intra-aortic balloon pump would normally be used to support patients with refractory hypertension after reperfusion, but a balloon pump is not necessary in a patient experiencing Bezold-Jarisch reflex, which is vagally mediated and reversible. There are 4 ways sinus bradycardia and hypotension can occur in an inferior or posterior infarction. Stimulation of cardiac vagal afferent fibers, which are prominent in the inferior-posterior left ventricle, supplied by the PDA. Ischemia of the sinoatrial artery, which arises from the RDA in 60% of the population. Ischemia of the AV node, which is supplied by the AV nodal artery, which arises from the RCA in 85% of the population. Vasovagal response to severe chest pain. This can occur in an infarct of any location. And either vagal stimulation or ischemia of the AV node can further cause AV block in addition to sinus bradycardia. Let's talk about post-MI aneurysm and pseudoaneurysm. Left ventricular aneurysms arise in 4% of patients who survive STEMI. Left ventricular aneurysms form when intraventricular tension leads to expansion of non-contracting infarcted myocardial tissue. LV aneurysms occur 4 times more often at the apex and in the anterior wall than in the inferior-posterior wall. LV aneurysms can range from 1 to 8 centimeters in diameter. When you have persistent, meaning more than 6 weeks out of MI, ST elevations in a patient who had a recent PCI who has no anginal complaints whatsoever, that suggests presence of an LV aneurysm or LV pseudoaneurysm. Get an echo to assess for the presence of either, and also assess for concomitant thrombus. The persistent ST elevations on ECG, which are considered a classic sign of LV aneurysm, have been shown to actually indicate a large size infarct territory and only suggestive of an aneurysmal segment. An LV pseudoaneurysm results from the rupture of the ventricular free wall contained by overlying adherent pericardium, whereas an LV aneurysm is an area of thinned out myocardium that is dyskinetic and involves the full thickness of the wall, no rupture. Pseudoaneurysm usually occurs at the inferior wall, while aneurysm usually occurs at the apex of the anterior wall. Pseudoaneurysms, which are contained rupture, are actually the more dangerous one as they are at risk for expansion and rupture and require expedited surgical evaluation, in contrast to alveolar aneurysms, which have no rupture and which are usually managed medically unless there is VT or intractable heart failure. Pseudoaneurysms can become very large, but still only have a narrow base or neck through which it communicates with the ventricle, whereas the base or neck of a true aneurysm is wide. If echo is non-diagnostic for aneurysm versus pseudoaneurysm, do a cardiac CT angiography or MRI to differentiate between the two. Other than thromboembolism and heart failure, LV aneurysm patients are also at increased risk for ventricular arrhythmias. LV function is most commonly is evaluated with TTE on day 2 or day 3 post-STEMI. In patients with significant LV systolic dysfunction revealed during the initial hospitalization, LV function should be re-evaluated more than 40 days later, especially to address the potential need for ICD after allowance for recovery of the EF from myocardial stunning. Other than looking at LVEF and looking for aneurysm, the post-STEMI echo is looking for mitral regurgitation, concurrent right ventricular dysfunction, left atrial enlargement, and diastolic dysfunction, all of which are also associated with worse prognosis after MI. So pay attention to those things when you're looking at your STEMI echo, not just the EF. Post-MI patients with LV aneurysm have 6 times the mortality rate compared to post-MI patients with comparable LV ejection fractions with no LV aneurysm. The sudden death that occurs in post-MI patients with LV aneurysm is usually due to ventricular tachyarrhythmias. Now let's talk about post-MI arrhythmias. An accelerated idioventricular rhythm, AIVR, is a wide complex rhythm arising from the His-Purkinje system. It can be differentiated from ventricular tachycardia by the slow rate of 60 to 100 beats per minute. AIVR is classically seen in the reperfusion phase of an acute STEMI, for example, post-thrombolysis, occurring in over 50% of post-STEMI revascularization patients, mostly in the first 2 days after infarction. Half of episodes of AIVR are initiated by a premature beat. The other half of AIVR episodes emerge during periods of sinus slowing. AIVR episodes may have variation in rate in the style of sinus arrhythmia. Unlike more rapid forms of ventricular tachycardia, episodes of AIVR have not been found to affect prognosis after MI. AIVR is usually a well tolerated, benign, self limiting arrhythmia. It resolves when the native sinus rate comes up and exceeds that of the ventricular foci. If AIVR is accompanied by hemodynamic compromise, treatment with atropine or atrial pacing will usually suppress the rhythm. Premature ventricular complexes, non-sustained ventricular tachycardia that is not associated with hemodynamic compromise, and accelerated idioventricular rhythms that emerge after reperfusion after a recent STEMI do not require specific therapy. Bradycardia is common following acute MI, especially in patients with an inferior MI. Sinus bradycardia occurs more often than atrioventricular block. It is mediated through increased vagal tone, is usually self-limited, and generally requires no treatment. AV block and bundle branch block develop in approximately 5 to 7% of patients after MI. Mobitz type 1 block usually self-resolves within 72 hours after MI and does not require specific therapy as it is intranodal and almost never progresses to complete AV block. Mobitz type 2 block reflects conduction disease below the bundle of His and generally needs pacemaker replacement as it may progress to complete heart block. Post-MI Mobitz type 2 block almost occurs always in the setting of anterior infarction, whereas post-MI complete heart block occurs in either anterior infarction or inferior infarction. Complete heart block occurs in 1% of anterior MIs and 3.7% of inferior MIs. In inferior infarction, complete heart block usually evolves from first degree to second degree Mobitz type 1 AV block with a stable escape rhythm and is transient with spontaneous resolution. In contrast, in anterior infarction, complete heart block may develop without warning, although it is usually preceded by second degree Mobitz type 2 AV block. In patients with symptomatic or hemodynamically significant bradycardia, sinus and/or AV block, it is reasonable to administer intravenous atropine. If the rhythm is medically refractory, then temporary pacing is indicated. High-grade heart block that occurs with inferior MI is usually not due to infarction of the conduction system and will resolve over time, so permanent pacing is usually not necessary. Permanent pacemaker placement should be reserved for those with persistent sinus node dysfunction or high degree AV block after a waiting period following the MI. If someone has NSVT, non sustained ventricular tachycardia, after MI plus or minus reperfusion, you can up titrate beta blocker to blood pressure and heart rate tolerance. NSVT is very common in the 24 hours after MI with or without reperfusion. Do not use amiodarone or lidocaine. In fact, when enconide and flecainide were used to suppress non-sustained ventricular tachycardia after MI in a cardiac arrhythmia suppression trial, CAST, it increased mortality. So just don't do it. Beta blockers are sufficient. Post-MI AFib is usually transient, occurring during the first 24 hours after infarction, and occurs more commonly in patients with LV failure, infarct-associated pericarditis, or ischemic injury to the atria. Post-MI AFib is associated with increased mortality, partly because it occurs more frequently with extensive anterior wall infarctions. Rapid ventricular response and loss of atrial conduction to ventricular filling may lead to reduced cardiac output. Now let's talk about post-MI papillary muscle rupture and interventricular septal rupture. The posteromedial papillary muscle is more prone to rupture than the anterolateral papillary muscle due to its single blood supply from the posterior descending artery. In contrast, the anterolateral papillary muscle is supplied by the left anterior descending artery and the left circumflex arteries. Therefore, if the infarct was LAD, do not select papillary muscle rupture on the test. Suspect interventricular septal rupture first. If the infarct was inferior, then you can suspect papillary muscle rupture. While echo is pending, the diagnosis can be made by the presence of a new systolic murmur in the setting of hemodynamic compromise. But note the MR murmur may be silent due to rapid equilibration of the left atrial and left ventricular pressures. Papillary muscle infarction and necrosis can cause the new systolic murmur, that's the MR murmur, and pulmonary edema in a progressively unwell patient, whereas papillary muscle rupture will cause immediate decompensation and can be fatal due to the severe and rapid onset mitral regurgitation. Papillary muscle rupture from MI has high mortality and needs emergency surgery with mitral valve replacement rather than repair. Afterload reduction with medical therapy and an intra-aortic balloon pump may be considered as a temporizing measure until the patient can be taken to the operating room, but should not delay definitive treatment, which is surgery. Ventricular septal rupture, which occurs 3 to 5 days after MI, usually occurs from a wraparound LAD artery infarct. In the days of fibrinolytic therapy trials, rupture of the intraventricular septum occurred in only 0.8% of patients, but had a staggering 30-day mortality of 74%. A ventricular septal rupture can present similarly to a papillary muscle rupture. Both will have a new holosystolic murmur on physical exam, and both murmurs will decrease or disappear if arterial blood pressure and therefore systemic afterload declines. On right heart cath, both will have tall V waves on the pulmonary capillary wedge tracing, both ventricular septal rupture as well as papillary muscle rupture. However, due to left to right shunting in ventricular septal rupture, the PA saturation won't be as low as the 40s. Also, measurement of oxygen saturation via PA catheter will detect a step up in oxygen saturation in the right ventricle as a result of oxygenated blood entering the right ventricle from the left ventricle. On physical exam, ventricular septal rupture may have a thrill, while papillary muscle rupture will not. Ventricular septal rupture will not have pulmonary edema or crackles on exam. To repeat, papillary muscle rupture causing acute MR will cause low PA saturation in the 40s, will have no thrill, and will have pulmonary edema and crackles on exam. Ventricular septal rupture can only occur with large infarcts, but papillary muscle rupture can occur with large or small infarcts. Half of papillary muscle rupture cases are from small infarcts. Rupture of chordae tendineae is a major cause of mitral regurgitation, but has no role in a myocardial infarction. MI does not cause rupture of chordae tendineae. Chordae tendineae rupture can be caused by infective endocarditis, trauma, rheumatic fever, myxomatous degeneration, and congenitally abnormal chordae. Posterior chordae rupture spontaneously more frequently than anterior chordae. Now let's talk about post-MI free wall rupture. This one is very bad. Rupture of the left ventricular free wall typically occurs after a large MI in the LAD territory at the junction of infarcted and normal muscle. The incidence of 5% occurring within 3 to 6 days after MI are from old case series. More recent studies quote an incidence of 1 to 2% occurring 48 hours after presentation. Post-MI left ventricular free wall rupture occur in patients who have had delayed presentation after MI, and especially those who may have been physically active after the onset of MI. Other risk factors for LV free wall rupture post-MI are elderly age, female sex, history of hypertension, and absence of previous infarction. Interestingly, patients with prior MI are thought to be protected against rupture because previous scars may reduce the magnitude of shear forces between the fresh infarct and the healthy myocardium. The rate of free wall rupture is lower after PCI than after fibrinolytic therapy. The survival of free wall rupture is poor due to instant hemopericardium and cardiac tamponade. Now we'll talk about stent thrombosis. Stent thrombosis is considered acute if it occurs immediately after stent implantation, subacute if it occurs in the first month, and late if it occurs after that. The current second generation of drug-eluting stents have lower rates of stent thrombosis than bare metal stents and first generation drug-eluting stents and should be used for any PCI regardless of anticipated DAPT duration. The strongest predictor of stent thrombosis is premature cessation of antiplatelet therapies. Other factors that increase the risk of stent thrombosis are stent placement in small vessels. That's why we avoid placing any stents that's less than 2 millimeters or even 2.25 millimeters wide. Long stents. That's why we try to avoid giving full metal jacket in patients. Overlapping stents, which is why we try to only have a couple of millimeters of overlap between stents. Multiple lesions, which is why we try to send patients with multiple lesions to CABG surgery. Ostial or bifurcation lesions. Prior brachytherapy for ISR. Suboptimal stent result, for example, underexpansion or residual dissection. That's why it's important to IVUS post-stenting to detect for underexpansion or residual dissection, especially at the distal stent edge. Low ejection fraction, diabetes, or kidney failure. These are the factors that increase the risk for stent thrombosis, other than premature cessation of antiplatelet therapies. Now, briefly, just want to say a couple points about post-MI findings. Gadolinium is an extracellular contrast agent that only minimally enters normal myocardial cells. However, disrupted myocardium after an MI allows expansion of the volume of distribution and delayed entry of the contrast agent into the affected region. A subendocardial distribution is indicative of MI. Having the transmural extent of late gadolinium enhancement less than 50% is predictive of functional recovery after revascularization for an MI. That's all for this episode on complications of MI.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.